So today's topic's on hospice, and this recording will be available as well as all the week's recordings on heartfelt.org, and then under resources and aging with Dr. Cheryl. So past recordings will be on there, and also other resources. We've talked about checklists and websites and things like that. So all the resources are there. So today I wanted to talk about hospice, what it is, who gets on it, when, and um, and answer questions that you may have, etc. So I have been a geriatric care manager for over 20 years, and I first started kind of being interested in aging and hospice actually in my mid 20s when one of my grandmas ended up going on hospice, and I'll tell you about that story in just a moment. So fast forward, then I went back to school and became a social worker and started working in different environments with aging. And one of them was I was a hospice social worker. I also worked in hospital discharge planning, assisted living, memory care, adult daycare, inpatient psychiatric, uh, geriatric psychiatric work. And probably one of my most favorite places, or there's not a word for it, but spaces, whatever, was hospice work. So what is hospice? So hospice is a specialized, it's a medical treatment, but it's also a holistic view on caring for someone with some type of terminal illness. And it's subjective when someone actually starts on hospice, because what they look at is there's certain regulations that Medicare sets up for each disease that says if this disease progresses like it normally would, this person would have 6 months or less to live. Now, any hospice social worker, any hospice worker will tell you there's just no way to know exactly how long someone has to live, but that it's a general guideline, 6 months or less to live. Now, you may have heard about something called palliative care. So there's two types of care when we get closer to the end of life. So there's hospice, 6 months or less to live. And then some insurance companies, agencies offer what's called palliative care, and that's approximately 1 year or less to live. So what's the difference? Usually it's, well, usually it's about how much Medicare will cover. Medicare will cover 100% of the hospice care. So the bills for hospice will be covered 100% by Medicare, and palliative care is covered 80%, and 20% is yours to pay. So that's a glaring difference. But in the generalities, palliative care, you'd have a little bit longer to live. So I've got a really funny story about that, but it's not the time yet. I want to tell you, but I'll try to remember that in a couple minutes, about the difference between those two programs. So to qualify, someone needs to meet the requirements that Medicare sets up. The one important thing about hospice is that, it's changing over the years, but it still is that many times the patient, or the family needs to bring up the subject to the medical team about hospice. The medical field is still focused on curing things, living a longer life at any cost, trying treatment. And it's changed over it's changed over the years. So, that was 30 years ago that I was with my grandma for the first time with hospice. And so it's changed, but still, uh, it's still the case. So I'm going to give you information today so that if you come, to that decision point yourself or you're helping a loved one, that you will feel empowered to talk to your doctor or nurse about hospice. So hospice is typically um, im- the diseases, the illnesses that you'd see someone typically go on hospice for, different types of cancer, heart disease, lung disease, Alzheimer's are very typical uh, seen on hospice. And it's usually the the time I would say, like, you go when it's usually at a change of condition. And actually, that's one of the diagnoses that qualifies someone for hospice is change of condition in in an illness. Say someone has lung disease and they're getting treatment, and then they just they're going along pretty fun, pretty good. They're hanging in there, and then something changes, such as a lot of weight loss in a short period of time, severe fatigue. They're not able to eat. They feel nauseous, very lethargic, and they just can't kind of get over that. That's a change of condition, and those kind of things would be typical of someone requesting hospice. So I'll give you the example of my grandmother. One of my grandmothers, I was probably about 25, and she had endometrial cancer. She lived across the country from me. I was young. I was focused on sports and getting a job and playing and stuff like that. I had no idea about hospice. I had no idea about cancer. All of that was just foreign to me. But I knew I loved my grandmother. So I went to visit her a couple times and she at home and she was kind of declining. And then she ended up going to the hospital. And I remember just sitting in in her hospital room with her, and she wasn't doing well. She was very lethargic. She wasn't eating much. She'd lost weight. And I just sat there loving her and, talking with her. I felt like the hospital had it under control. The doctors knew what they were doing. I just was completely at their mercy, I guess, leaving all the decisions up to them. And for some reason, my mom knew about hospice. And then she started asking the doctor, because he was saying she needs more chemo. She needs more chemo, which she had been going through chemo before and stopped for a while. And what brought her into the hospital was she couldn't walk. Wasn't strong enough. So my grandpa was like, help, needed to help her to the bathroom and to the shower. It was just he got to his wit's end, and that's why she ended up in the hospital. So the doctor's like, more chemo, more chemo. And my mom started asking him, this doctor, what about hospice? And he would say, no, no, no. And so this went on a couple days. And so I was just observing it. Still didn't know about hospice. And so finally, we had a meeting with the doctor, my mom and me and the doctor. And he said, almost in these words, okay, if you want to kill her like that, fine, she can go on hospice. And I was like, how do I even take that? So later that day, the hospice social worker and nurse came into the room. And what's interesting was actually in the next room from my grandmother's, the next room over was the hospice office, and even said hospice on the door. But they couldn't talk to us until the doctor said, okay, gave her the prescription, the referral to the hospice. And I just remember it so clearly that they came in and they looked at my grandma and they're like, oh, this is happening. This is happening. This is happening with her. Like her skin looked a certain way. Her blood pressure was a certain amount. Her pulse was a certain amount. Uh, and they said, she's probably got about 3 days to live. And I was shocked. I was like, like, we're going chemo, chemo, chemo. That meant, to me, that meant she's going to live. Uh, to like, these people are saying this, she's got like less than a week to live. And as a matter of fact, she did, because closer to the end of someone's life, there have certain signs that you're like, yes, that's pretty sure that that person's going to be leaving us. So what that offered me was a time. We told people, we told the family they could come say goodbyes to her. We could talk to my grandma about what was going on with her body. Um, and in fact, she did have, so because of that, we helped my grandma create just a beautiful ending to her life and have completions with friends. We had a beautiful, we turned off the cold lighting in the room, and we had candles, and um, just made it really a beautiful experience. And it hit me that day when the nurses were telling me this. Like, this happens every day. This is how people die. People die. This is what it looks like when they're dying. And because I didn't know that, and I was just dependent on the doctors to tell me what was happening. Um, that was when my whole trajectory to working with older adults and their families started. I felt so empowered when I got the information, and I was like, this is knowable, and people need to know about this. So, what would have happened if she would have had more chemo? Maybe she would have been around another week, maybe, but it would have been a really awful quality of life, and it just really, she wouldn't have gained anything. So that's my that's kind of the start of my hospice journey. And so when I say today, and it still happens with uh, the family really needing to ask the doctors or the nurses. Now, this was 25 years ago, so most doctors aren't going to respond the same way as kind of harshly as this guy did. And I chalk it up to, I understand his point of view, that his job, he felt very passionate about his job, was to help her live longer, even if it was a week, or those were all the tools in his toolbox. So when we talk about hospice, we really talk about the quality of life. And when someone signs on to hospice, meaning they say, Medicare, you're going to pay for this hospice service, they are saying, I want comfort care. I want my symptoms of my illness to be controlled. So if they're in pain, I want some pain medicine. If I have nausea, I want something to do that, to handle that. And the hospice team is really specialized in this kind of work, to handle so that the symptoms are decreased and people can have a high quality of life. So there are a lot of hospice agencies out there. There's some for-profit, some nonprofit. Um, if you live in a small town, you may have maybe some fewer choices, but in a larger town, I mean, you'll have, probably 20 choices of different agencies in just a region. So the patient can choose any hospice agency that they want. Sometimes if you're in a hospital, they have hospice agencies that they always refer to. You could use that company, or you can go with your own. If someone's at an assisted living, I often suggest to find out who the assisted living already has a great relationship with, and use that agency if they're already happy with them, because that company is going to be there for other clients, and just more convenient that way. So the hospice team, when you sign up, you say Medicare, pay for this, and you sign the forms to say, yes, I want hospice. What you get on the team is you get a nurse, a social worker, a chaplain, a home health aide, and you'll get a medical doctor. There's a medical doctor that's connected with every hospice agency. So the nurses will come out to the house. Usually, hospice is offered in the home. I noticed in some states they do it a little differently. In my area of Southern California, almost 100% it's offered in the home or in assisted living wherever the person is living. My dad was on hospice probably 10 years ago in Florida, and they have a small wing of the hospital that offered hospice. So for the last week of his life, he went into hospice in this hospital. So sometimes it could be in a different setting than home, but you always have the same team. You have the nurse, and usually they will make 1 to 3 visits a week, and their visits might be 30 minutes, an hour, hour and a half. And so they'll come out 1 to 3 visits a week, depending on what the person needs. If they're kind of just in maintenance, they're going along, they might visit once or twice. But if the symptoms increase or if they need more help, the nurses could come out every day if they needed to. And they are available 24 hours a day. So it's a beautiful support for family at home. If the loved one is having a shortness of breath in the middle of the night and they don't know what to do to comfort the person, you just call the hospice agency and they can usually talk you through it over the phone, what medication to give or some suggestions. And if they can't do it over the phone, the nurse will come out to visit 24/7. There's also a social worker. She'll help with bereavement support, anticipatory grief, um, funeral arrangements. If someone needs home health aides or caregivers in the home, they can help refer that to that. And then there's also home health aides, and they usually come out twice a week to help bathe. And again, that visit's maybe an hour long. So sometimes people think, oh, I'm going on hospice, I'm going to have a caregiver here 24/7, or the nurse will be here 24/7. That's not accurate. And the family provides that extra support. So the nursing, social worker, chaplain, if you want to come out to the house for short visits. But besides that, it's family helping out. If you're at assisted living, there's caregivers there that can help. And so sometimes the families need extra support so they can hire a private caregiving agency to have, sometimes if there's maybe just one person at home and that person needs to sleep and not be up all night with their loved one, they can hire a caregiver so they can sleep. Sometimes they need to, if the person needs help all the time and they need to get groceries, the caregiver can go help with that. The one other thing that is provided with hospice is a volunteer. They've got a great volunteer program, and the hospice also provides bereavement for a year after the person passes away. So sometimes a volunteer is available and the family needs, hey, I need some groceries picked up, or I need someone to sit here with my loved one. The volunteer can help with that. So it's a personal decision whether someone wants quality of life versus curative treatment at some point. So that's something to talk with your family about at the time, or your loved one, and then the doctor as well. Oftentimes, the medical team just needs an opening for you to ask, hey, what if I don't do that treatment? Then what? I had a neighbor that was recently he had lung cancer. He'd been done treatment, but the cancer came back, wasn't curable, and he was at home. Finally went to the hospital, and at the hospital, the doctors were saying, "Okay, you need more treatment." That's the word again. They were going to give him more radiation, but it wasn't curable. So it was just to make it, the tumor smaller, maybe to give him a little bit of help to get it, again, it might have bought him another month of life potentially, but the quality of life when he got that month wasn't going to be good, and it was going to go back and forth to the hospital, and the hospital, like, to get radiation was like a half an hour away. It was a lot. So, but they didn't give him the option of you could do the treatment or not. They just gave him the option of you need this treatment. So he was thinking that I need that treatment. So when I talked to his daughter, who doesn't know about cancer, doesn't know about hospice, and informed her like that there is an option, and you guys can ask about hospice. And then they talked to the nurses, and the nurses like, "Oh, I'm so glad you asked. Here's this other option." So they were really happy to talk about it, and they even thought that he needed it, but they couldn't, for some reason, that hospital or insurance company, that wasn't their protocol, that just offered it. So he ended up coming on home on hospice, had a fantastic life for a week, and he he just had everything he wanted at home. And he even said, like, "Hey, if I knew this hospice was going to be so great, I would have started earlier." So, um, lastly, I think the only reason not to go on hospice, because I don't see a reason not to go on hospice. People can graduate from hospice. If you go, "Hey, you might be dead in 6 months or less," but if they get better, a lot of people they feel better when they come home on hospice. It doesn't necessarily mean they're going to live that much longer. They may or may not, but they feel better. They can graduate from hospice, meaning they can just go off of hospice until they need it again. The 6 months isn't a hard end date. We had patients on hospice for a year or two if needed. Sometimes someone will sign off of hospice and come back on, but if it's needed for the support, you can stay on hospice. I'll tell you one funny story. So, um, my father-in-law had lung cancer, and he was home on a lot of oxygen. And the insurance company comes out, and the insurance company sends a nurse out to describe their programs to him. And this guy wanted to live. He wanted to live like more than most people I've known. So the nurse is describing, like, this is your condition. So we have two choices. One is hospice. And he just stopped her right there. He's like, "I'm not going on hospice. Hospice is a give up program." And she's like, "Oh, no, no problem." So we have this other program. It's called palliative care. And palliative care is covered 80%, you pay 20%, and hospice is covered 100%. And he said, "Sign me up on hospice." Because for him, it was all about the word and the money. He was the most frugal person I've probably ever met. So it was just the word. It was going to be the same exact care at home. So he just had to get over in his mind what was hospice. So I think that's the only thing that I would say is like a negative to hospice, is that some people just need to get their head around the word so that they don't feel like they're giving up. Because really, hospice is about getting as much life and quality of life as possible for as long as someone's going to live. So um, I was talking to Nancy, and I'd love for her to share a little bit. So sometimes when you're talking with people about hospice, or just in the end of their life in general, sometimes a loved one will hold on and want to stay. And if you're like, "Hey, this person looks like they you know uh, they they should be gone, they should be transitioning, but they're hanging on. What's going on?" Sometimes they need their loved one just to say, "Hey, I'll be okay without you," or "It's okay to go," in a really gentle way. And I would love Nancy to share about this topic at a great point of view.
Okay, so tell me you can hear me.
Sounds good, Nancy.
Great. So eons ago, I would say 1980, 81, something like that, Brotman Medical Center at the time. They've renamed the hospital as a corporate place now, I think. But they had a fabulous program in Culver City called a life transition program. And it functioned in two ways. One was thanatology counseling, that's a word for death or dying. So counseling the dying one or the patient. And the other branch of it was grief counseling for the family. So I never knew why I was drawn to work with him. It was a puzzle to me, but I was definitely drawn to work and to get trained and all the things you do. So one day I walked into the hospital room of one of the patients I was seeing, and it was a party. I mean, the room was full of people gathered around the bed and elsewhere. They had brought in a little food and drink, and everyone was having a great time. And the patient called me over, and I leaned down and listened to what she had to say. And I said to her, "Really, do you want all these people in here?" And her response was, "No, I wish it were quiet." And I said, "Well, you could ask people to leave if you want to do that. It's all right." And it was as if I had given her permission. And her voice got a little stronger at the time, and she said, whatever she said about, now I need to be alone or need to be with the doctor or whatever it was she said. She also, a wrinkle to the question or to the story is that her parents were on the East Coast, were told of their daughter's condition, and decided to drive from the East Coast to California to say goodbye to her. And so she told me that, and she said, "I wish they were here. I don't know whether I can hang on for 3 more days or something." And I was kind of inspired to say to her, "You could leave anytime you want." And it was like, "Really? Can I?" And I said, "You certainly have my permission to do that." And within an hour, she was dead. And a look of peace was on her face. And it had worked for her to give up everything she was hanging on to in life because of other people rather than her own needs. Another wrinkle to this was the doctors were being very attentive. I found myself, in fact, counseling some of the doctors, some of the oncologists anyway, because as Cheryl has said, their training, at least at the time, their training was to keep somebody alive and to keep testing to find out what stage they were in and so forth. And within a couple of hours before her quote party, the doctors had her down on the floor where all the machines were for more tests, which, I mean, I'm just a layman in my way, but I could tell it was past that time. We already knew she was fading away, and the testing was redundant at the very least. So that's my story about being close enough to a patient that they're willing to share with you what's real rather than what's other people expect, I think. Also, Cheryl, I wondered if you could say something about insurance in terms of hospice. How do you sign up for it? Do you need to be on Medicare as your insurance, or is it something else? I mean, I've lost track because I was talking about my experience 40 years ago, which certainly has changed in the interim.
Mm-hmm.
So back
Thank you, Nancy. Yeah, thank you, Nancy. So I would say that probably the majority of people on hospice would be covered by Medicare. Um, I don't know the percentages, but so Medicare's, if you're 65 and older, I would think most, end stage diseases, but certainly not all, would be in that group. So um, Medicare covers hospice at 100%. And even if you're in an HMO or, you know, variety of different insurances that are covered by Medicare, like if you're on SCAN or Blue Shield, Blue Cross, AAA, or AA, AAA, um, those are all they're all covered. Um, and if someone has other insurance and they're not on Medicare, um, they need to check with their insurance company. But it's a benefit that's well covered. Let's just put it that way. It's sort of and things happen in a timely way. It's like we have to wait to the last 6 months of our life to get insurance and the medical system to move at the speed of light that we would normally want at any point in our life. But um, it's covered and they're quick because they know time is of the essence. I think that answers your question. How do you get on hospice? So you do need a doctor's referral, but you so someone so a lot of times people will be in the hospital before they go on hospice. So you can ask the nurse, you can ask the doctor there, say I want to be referred to hospice, and then the doctor makes the referral. If a doctor doesn't make the referral, you could actually call a hospice company directly and say, "Hey, I'm at home or I'm in the hospital and I want to get on hospice." Their team can reach out to your doctor or a doctor and do an assessment and see if you qualify. So there are qualifications. Each disease process has their own regulations. Say if you have something with your lungs, maybe it's your oxygen that needs to be at a certain level, uh, maybe some different blood tests that need to be at a certain level um, before you qualify. If someone has Alzheimer's, maybe they have to have certain symptoms. A lot of times with that, it's significant weight loss, inability to eat by yourself, things like that. So each disease or illness has their own qualifications, but you can you can either ask a doctor or call a hospice agency and have an assessment, and that's how you get on. So the assessment nurse will come out and decide, do you qualify for hospice? I find most people, I more than not, they wait too long to get on hospice. So it's less typical that someone calls for hospice and you're like, no, it's not time yet. Um, you know, Sometimes people wait till they're, within the last day or two or week of their life where they could have been on hospice and getting comfort, care, and support for months. So that's what I'll say about that. And everybody, is kind of uh, adding to what you were saying, Nancy, that everybody kind of does end of life differently. Um, the family does it differently. Some people will show up at the bedside. Some people cannot show up at the bedside. That's sometimes, especially if someone's visually sensitive, they may not be able to see their loved one close to the end of their life. So maybe they'll just call on the phone. So, just trust everybody does it differently. And, there can be some disharmony in families if they think at the end, like, well, you didn't show up or you did show up. Like, so people are just doing the best they can with that. There's a great book called Gone from My Sight, and it's available online. And it's got a section in there. It's actually chapters that have these are the symptoms, say 3 to 6 months of life, a month of life, weeks, days, hours, and it lays out what the body goes through. Like I was talking about with my grandmother, that close to the end of their life, of one's life, the body does certain things that are kind of predictable. So that's, sometimes when someone gets on hospice or they're close to the end of their life, their family's like, okay, I'm going to take off time of work because so I can be there. But like, how long is this going to go on? And so sometimes some people want a reference point. And so sometimes you can see like that, especially with the nurses when they come in, when they're doing the blood pressure check and the pulse and so the vital signs can kind of show what the body is doing. And like I said earlier, every hospice worker will tell you that there's just no way to predict exactly when someone's going to pass, except for those, I'd say like the last couple days of life. Some people would come on hospice service and we would, the team would be like, this person does not even look like they're sick. They're going to be here a long time. And boy, they would, transition really quickly. And sometimes the opposite. So, most of the time when you ask someone on hospice, a worker, how long does my loved one have? They'll first say, I have no idea. I can't tell you, because really they can't. And then just feel free to go like, look, I'm not going to hold you to this. Can you just give me some, guideline as far as what you're seeing? Because most of the time they won't tell you. So it's another opportunity for you to advocate and ask questions. John, I
Carol?
see oh yeah, Nance.
Yeah, if I could add a couple things to what I was talking about. One of them
Hmm.
is, as far as I understand it, Medicare is underwritten or supported in certain ways by the US government. And given our shaky, our questionable political situation these days, it would be important to keep track of where the government is in its willingness to continue to support Medicare efforts because it's such I'm sorry, hospice efforts, because it's such a valuable resource to all of us. I say that because more and more people are getting older as we speak, including myself. And it's hard to know how it's going to shake down in terms of willingness to support the growing number of older folks who need help in the way we're talking about. Also, I ended my previous comments with how we talk to our patients and encouraging us to, like, what are we doing there? What am I doing there at a bedside of somebody who is passing away? And inside of me, there is something beautiful and miraculous that is happening because those of us who have studied with JR or John or had some kind of training in spiritual thought, we look upon it in some ways as another initiation. And that life goes on. Life goes on. Our life goes on. Our life in the great ocean of love and mercy. So it's a beautiful thing. So as I said, I'm sorry, my throat has not been behaving the way I wanted to in the last couple of days. So a long time ago, when I first started doing this work, I had to think through what it was I was doing there. And I came to the realization that, among other things, or maybe the most important thing, is I was there to help somebody appreciate and value their life, the life that they had lived. I'm reminded of a person who was a patient of mine who had an adversarial relationship with her sister, and the two of them hadn't talked in years, and the mother was involved somehow as well in the conflict. And we talked about it, and she came inside herself. She herself did this. I was just there to help her see or listen to herself, really. And as she listened to what she was saying, she came to a place of compassion for her family members, which helped her shed years of discomfort and disease and pain and so forth, and made her passing a lot easier. So it's something to think about. helping
Mhm.
somebody value the life that they've lived. And many people do not. I'm in at the moment and have been for a couple of years in an assisted living facility, and had the opportunity to talk with a lot of people over the dinner table and so forth. And it's astonishing to me how many people don't value what the kind of life they've lived. So my untold till now mission here is just to listen, to be a listener, and to help people talk about their life. That's all I had for now, Cheryl.
Mhm. Thank you, Nancy.
Thank you for listening.
And there's a comment in the chat. Have you read the excellent book Being Mortal? A must read. So I have read that book. It's a good one. Thank you, Susan. Just really quickly, I realized that a lot of the talk today was about um, the doing parts of hospice and what the team and how you sign up and the insurance coverage. And there's so much more that we could talk about as far as the being present and the presence and being with someone that's dying, and like Nancy was saying, validating their life and being with them, um, helping them make meaning. Uh, Part of the reason, well, the reason that I love hospice so much is that I found that's actually where people are living. So often people kind of walk around, I'll get to that tomorrow. Oh, I'll put that off till next week. When I retire, I'll do, you know, we've all done that. And sometimes we're on this treadmill of life and just going along. But when someone gets a life limiting diagnosis or goes on hospice, things can get very real. When they know I just have 6 months left here, or I have 2 weeks left here. So I love that. I have seen miraculous um, healing in families. It's possible. Doesn't happen every time, but it's so possible. And just I think this portal kind of opens to the sacred, the divine. Um, I was with one of our family friends close to the end, and I was his person, and I go spend time in the hospital with him. And he was kind of this guy kept people at arm's distance, never let people in. And about a week or two before he ended up passing, I was just sitting with him. We're talking and being real, and he knew I was there for him, and we would laugh. And I think he was joyful for the first time. Before that, he's like, I don't do happy. And but just a great guy. He was smart, caring, um, and he really was letting down his guard. And he looked at me and he said, I really wish we would have more time like this. And I just said, you weren't ready before this, but just enjoy it now. And I was telling him, like, well, what if, because he was starting to get nervous about where do I go when I die? And he just never had a belief. I was like, what if we just fall into the arms of loving, like more of this, what's happening here between us? And maybe it's like a big water slide and your arms are up and you're, yelling with joy, and you just fall into the arms of loving, into this ocean of love and mercy. And he just got this big smile on his face. And there's so many times like that, I could go on and on with stories about helping people complete things that they always wanted to do. The woman who always wanted to graduate high school, and so we had a ceremony, a GED ceremony for her, and she felt like she graduated high school, and then she could pass away. Or the guy that he always wanted to go to the Grand Canyon, and so we made that trip happen for him, and he could die had gone on he'd made it to the Grand Canyon. There's so many stories, so it's a beautiful, beautiful time in people's lives, and to have that support from the medical team that someone can be their symptoms can be controlled, their family can be there in support, and when the family has the information, like, hey, your loved one has X amount to live. This is what's going on, and so people can, if they can come together and just have a great quality of life. So maybe it's not quantity, but it's quality, and it can be just a beautiful, beautiful thing. And um, I've been with, you know, many people that have, like, as they're transitioning, like seeing them, being with them, holding their hand when they're taking their last breath, and seeing how beautiful that is and how peaceful, and seeing loved ones who had never had the privilege of being with someone that's passing, and that them going from being afraid of it to embracing it and seeing how beautiful it is. So, anyway, if you catch the spirit of that. So, John, I see your hand up. If you have something you want to share.
Yeah. Am I audible?
I hear you.
Thank you. Well, I raised my hand with a quick clarification question, but I really just, in the meantime, a lot's gone on just in terms of what's been presented, and I'm just kind of blown away by all of it. The the background that you shared. I mean, this has just opened up this whole um, inquiry process inside of me. But um, I and kind of just painting a picture of, you know, what hospice is. I realized I really didn't know what hospice was. Um, like I just sort of pictured some kind of like medieval room, you know, that where people were dying. I mean, I knew it was more cheerful than that, but hopefully. But I mean, just that it's like, oh no, it's like mostly at home. It's like, oh, okay, yeah, that sort of fits with what I've been hearing people say, but I hadn't figured that out exactly. And then Nancy, like what you shared is really very profound. And I use too many words. And Nancy's was sharing that her ministry, as she put it, unspoken until now, which, you know, was listening. I was like, oh, yeah, I remember writing that down in the last year, that that was the most important thing I had to learn. And I can testify my experience of Nancy is that Nancy does that extremely well. And, you know, she was sharing this experience at Brotman Medical Center from 1980. That's when I met Nancy, probably, you know, right around there in 80 or 81. I went to Friday night seminar at Prana, the recorded seminars, and Nancy was there. And there were two people that I remember that were kind of like, and I didn't know enough to know that it had nothing to do, the movement of spiritual inner awareness had nothing to do with people's personalities. And, but there was one personality there that I thought I judged, probably because they were like me. And whatever it was I judged them about, I thought, oh, is that MSIA? And Nancy was like the one, Nancy was the good one in my mind. Of course she was, but that other person I haven't seen in many years, decades around MSIA, but Nancy's just this kind of person that, I mean, I'm speaking to a lot of people here who know Nancy pretty well. And, but anyway, I just taking the opportunity to say thank you, Nancy, for being that example to me. And 43 years later, maybe I'm finally starting to catch up a little bit to what that means. And thank you. And my my quick question is just with insurance, um, like when you're talking about Medicare paying for hospice, I'm kind of guessing you're talking about Medicare Part B, paid Medicare. not Part A, unless, of course, it is covered by Part A, and that's my question.
That's a good question. I know Medicare Part A is hospitalization. Let's see. Hospice.
And posted.
Hang on a second.
So I think the American
Oh,
people
they're going to talk about that. Covered. Yeah. Well, there you go. Hang on. I'm going to find out for you. Covered under Medicare Part A. Let's see.
If it's too complicated, I mean, I can Google it too. I don't want to waste people's time.
So hospice Part A covers inpatient, skilled nursing, and hospice care. So it's Part A.
Oh, wow. So that would mean those unlimited as necessary visits by in your home, and which is a little counterintuitive considering they seem to be real sticklers about, like I was told, don't even go to a urgent care if you have Part B, that it's or if you have Part A only. It's like it has to be a hospital emergency room. So that's very interesting.
Right. So yes, with hospice, again, some people think it's just a, the nurses are just going to do everything. It would be like, 24-hour care. It's not that. And the nurses are available to make visits as needed. So if someone's symptoms are out of control or need assistance that way, they will send nurses out. And actually, if the symptoms are out of control, meaning the person is in pain and they can't get the pain out of control, they will have the nurse stay there for sometimes hours until that pain is under control. That doesn't happen a lot because they're experts at this and they know ahead of time how to manage the pain. But if it's needed, they'll be there. So, right. I think
that's awesome.
So, be careful about what, and I'm saying that the nursing visits are available, but there's a lot of time, like if someone's at home, there's a lot of time that it's just the family doing the support with the nurses as an extra support. So it's great to have, they're brilliant at, like, you call them and they'll help you out or send a nurse to handle it, but they're coaching you through it. They're giving you the medicine, so you have the medicine at home. They're giving you phone support or sending someone, but there's a lot that's needed from the family to support the person on hospice. I hope that helps.
It really, all of what you shared, that and before that, really clarified what hospice is, and but it is only available in the end stages. Like I was thinking, like, hey, when Makeda's out of town, it would really be helpful, like for bathing assistance, just because sometimes the people don't want their male husband doing bathing procedures, and so it's just like that would be awesome, but it doesn't sound like that'd be some other type of care then.
Yeah, that may be like seeing if sometimes there are some assistance through like Medi-Cal, in-home supportive services.
Right.
That person, and bathing is low on my list of things that are required of a person. When someone doesn't want it, it doesn't bother me so much. If you talk to a nurse, they might think, oh, there's risk for infection or there's this or that. But this, especially with, people with certain conditions that it's a traumatic to have that happen. It's just really not important.
Yeah. Well, that's always nice to hear too. It's just kind of like, I mean, when you're dealing with somebody that's just spraying a hose on their hands, like they're like a cat, they don't want that water splashing on their face or something. It's just a different kind of experience. Anyway, I won't take up any more time. Thank you.
All right. Take care. Take care, John. Hi, Maritza.
My mother passed a couple months ago, and I know that the social worker that came mentioned, and again, my mother was 97. She'd been relatively healthy most of her life. She was walking up until about 10 days before she passed away. And she walked that much because she wanted to feel very strongly that she needed to take care of herself. Even though we thought you don't have to make such a great effort, she made sure she made the effort. But we had somebody during the day that helped out while my sister worked. She lived with my sister. And when she really essentially just went to a point where she stopped, she couldn't swallow. So, she could maybe take a spoonful of this or a spoonful of that. And rather than put, like intravenously things, they suggested, well, let's go into the hospice thing. And I figured that since she had already, in the last year, she lost a lot of weight because she'd been eating less and less during the course of the years. She had lost a lot of weight. I figured that she might not last, but maybe a week or two without really having food. And she was in bed, for about the last 10 days of her life. But we did get assigned a hospice social worker. The doctor was the one that recommended it. And I know at some point, and maybe to answer John's, to check into it, because I know that they asked us if she needed, my mother wouldn't qualify because my mother lives with my sister who has a good income. So, but I think that if we wanted more assistance, you would need to apply, and it would take a couple of months to get it. So maybe there's other things available for John and Lori that, if you have a limited income, that maybe for that care that maybe needed, for that person that needs that extra care. But I think that I would have, in hindsight, at least for my mom, it seems like she could have gone probably in hospice maybe 6 months before, just a thought. And she was dizzy a lot, and the doctors didn't want to give her anything because she was walking, or at least doing great effort to walk very slowly, but to make her this, to give her any medication that would make her even more dizzy or whatever, so because she would get up in the middle of the night and everybody would be asleep to go to the restroom. So anyway, it was just interesting. It was for me, it was an honor to be present at that moment in the life of my mother. I was able to be there, also to hold her hand and be there during the time that she took her last breath, and that was great. I thought it was a beautiful experience to be able to do that. And at the same time, even though your mom is 97, it's a very difficult experience anyway.
Mm-hmm.
And I, anyway, just thought I'd share a little bit about that. Thanks.
That's beautiful. Thank you for sharing that. Wow. 97 and independent and walking and so strong.
Showering on her own.
Showering. That's awesome.
Eating on her own.
Tenacious. I love that.
And saying, this is what I want to eat. Choosing which is great.
That's beautiful.
Thanks for the laughter.
Yeah.
You bet. My respects.
Yeah. It's beautiful. Thank you. All right. We're going to wrap it up for today. Thank you so much for joining us and for sharing. And I love you all. And if you have questions, comments, you could, or topics that you'd like to talk about, you could email us at serve@heartfelt.org. And thank you. Thanks so much. See you again.
Thanks, Cheryl.
Right. Thank
Bye,
you.
everybody.
Thank you very much.
Bye. Bye, Maritza.